This is a 68-year-old man who suddenly developed the worst headache of his life. You should already be thinking when you hear that, based on this lecture. He had a history of severe diffuse atherosclerosis, including coronary artery disease and peripheral vascular disease, requiring multiple bypass operations. He was also a heavy smoker for over 40 years. On the morning of admission, he was walking in the hallway at home, and at 10 a.m. he suddenly developed an explosive headache, worse than anything he had ever experienced. The headache began in the bifrontal area, and over the next few minutes spread all over his head and down his neck. He denied any nausea, vomiting, loss of consciousness, or vision changes. Examination was unremarkable, except for some mild nuchal rigidity. Y'all know what that means, mild nuchal rigidity? Okay, stiffness of the neck. It's probably something that when you're seeing patients, anytime somebody presents to you with a headache, that's something you probably want to document every time you see them. Just to basically say you thought about the bad stuff that causes headaches. Because this is one of the bad things that causes headaches. So what diagnosis, that first question, what diagnosis should be suspected in a patient that presents this way?
Subarachnoid hemorrhage.
Good. And what is the most common cause? Aneurysm. Good. An abdominal aortic aneurysm, or what's it called? Cerebral aneurysm. Cerebral. Berry is a type of aneurysm. Yeah. Very good. And what is the, we talked about the nuchal rigidity, so someone tell me what that means. What is that?
Meningitis. Or, sorry, I'm thinking
Yeah,
meningitis.
irritation of the meninges.
Exactly, good. But yes, meningitis is one of the things to think of. And then, so what would you do with this patient?
CT.
Non-contrast CT scan of the head, yeah. And then, you know, we've already established that he seems to be pretty stable, so you want to make sure blood pressure's stable, he's breathing on his own, all those typical things. You would draw blood work, probably a drug screen on anybody that presents this way. So this is a discussion. Maybe we'll read that. But we covered all of that. So the next thing you would do, and we don't really get into this in the lecture, is, so how else do you work up a subarachnoid hemorrhage? So this guy probably had, based on his presentation, I'm going to show you a CAT scan, but there's no way it could be this CAT scan. This is probably what we call a sentinel bleed. So it's a mild bleed. That aneurysm kind of leaked a little bit of blood, and it caused a severe headache and some stiffness of the neck, but he was still awake and alert and had no focal abnormalities. So we said the most common cause is an aneurysm, so how do you look at blood vessels?
Angiography.
Angiogram, good. And usually the neuroradiologist, at this point you would contact the neurointerventionalist or a neurosurgeon, but usually we would obtain a CT angiogram of the head, and I always include the neck because it's not extra dye, and it gives the radiologist more information about the arteries in the neck. Because this guy, you know, if you don't CTA his neck and then you find out he has a severe carotid stenosis when you get in to do the interventional, that's going to be something you want to know. So we did a CT angiogram of the head and neck after we've got the CAT scan and established that he's had a subarachnoid hemorrhage. What if the CAT scan is negative in this setting? What would you do next?
Probably the same
It
thing.
doesn't rule it out, so what's the next test of choice? Something quicker. Somebody said meningitis was on the differential. How do you diagnose that?
LP.
Lumbar puncture, yes, that's right. So what does a subarachnoid hemorrhage cause on a lumbar puncture? Blood. So it will be blood that doesn't decrease as the fluid is running, blood will be the same throughout. If you have a, because sometimes when you do a lumbar puncture, you tear one of the veins, part of the plexus, and it's called a traumatic cap, but the blood will decrease. It'll be really bad at first, and it decreases. And then the other finding is what's called xanthochromia. I'll write that down, because that's always a test question they like to ask about. Xanthochromia, and that's the kind of old blood that has been digested and causes kind of a brown tinged color in the spinal fluid. So they spin it down, and then they look at the spinal fluid after they spin it down and see if it has a tinged color. They do this in the lab. And then, how do you treat? He's stable, he has good perfusion. How do you treat the aneurysm to keep it from bleeding any worse? Because this guy's alive. You know, a large percentage of people don't make it to the hospital with a subarachnoid hemorrhage. So what's the treatment? What do we say to clipping it or coiling it? Yep. All right. And this is a subarachnoid hemorrhage. There's no way this is that guy's subarachnoid hemorrhage, though, because this person would be in a coma and not awake. But this is an example of what a subarachnoid hemorrhage looks like, okay? So he has right here this temporal horn, okay? This is the temporal lobe here. That temporal horn is dilated, so he's actually developed some early hydrocephalus, okay? So he would probably need a drain and very aggressive treatment. This is a conventional angiogram. So this is that, what type of aneurysm? You said it earlier? Berry, yeah. So this is the berry aneurysm here. Okay, this is the neck of that aneurysm. That kind of, the neuroradiologist, that's what they determine. So this is an aneurysm off of the internal carotid artery. Internal carotid artery is the most common place for an aneurysm. Internal carotid artery is the most common place for an aneurysm. I missed that test question. So, and another common place is the anterior communicating. That's probably the second most common. All right, case number 2. I'm going to go back here, sorry. So this is a 52-year-old right-handed woman who went to her doctor the morning after developing difficulty raising up her left arm. Past history was notable for hypertension, heavy cigarette smoking, and after supper on the evening prior to admission, the patient tried to reach for a cup of coffee with her left hand, but was unable to raise her left arm. As she turned to walk away, this movement caused her left arm to flop up in the air and slightly knock the coffee cup on the floor. She did not make much of this and went to sleep. The next morning, while shopping in the supermarket with her husband, she noticed that she could not raise her left arm to take items off of the shelves on the way home. And so she decided maybe I should go see my doctor. She sees her doctor. This is her exam, notable for a right carotid bruit. When he examined her eye movements, when she looked to the left, she kind of had a fast phase of optokinetic nystagmus. Okay, that means her eyes kind of just jerked over there, like she almost didn't want to look over there. Okay. She had normal fine finger movements. Power was 5 out of 5 throughout on the right side. So she had normal strength on the right. 5 out of 5 is normal. Her left arm, she had weakness in shoulder shrug and her deltoids, okay, tricep, and her bicep, all on the left side. But finger extensors and the hands were normal. Left leg power was weak in the hip flexors, okay, so the muscle that pulls up your leg there, and then was normal elsewhere, it looks like. She had an upgoing toe on the left. What is that called? Good. And she tended to veer to the left. When he tried to have her do a tandem gait, that's where it's the drug test where you have them walk in a line. She was falling to the left side. All right, so based on this, I know y'all can't read that very well, so abnormalities on her exam. So what's the major abnormality? What was her biggest problem? Her biggest deficit? With what?
Left-sided weakness.
Left-sided weakness, so her arm was weak. She noticed she couldn't use her arm. Seemed to come on suddenly. Her toe was up on the left. So where do you think her stroke is? The right hemisphere, okay? And that optokinetic nystagmus, what they were getting at is that she had a gaze preference to the right. So it was difficult for her to look to the left. That's what they were trying to tell you. And then she had an upgoing toe on the left, which is an upper motor neuron finding. Okay? That means that involving the brain or spinal cord can cause upgoing toes. Alrighty. So with this patient, she comes to your ER. You notice these abnormalities on her exam. What do you do next? Is she a candidate for IVTPA? No. Why not? Too long. Is she a candidate for endovascular therapy? No. Too long. Okay. So you give her things to eat immediately in the ER. She tells you she's hungry. No. Good. So you make sure she's stable. You start her on IV fluids. And you give her an aspirin. How do you give the aspirin? We can't have her take it by mouth. Up the butt. Rectal. So, rectal aspirin. This is a common mistake. I'm being funny, but this is a common mistake that Holdenville ER makes. They send us these patients and then they've already aspirated because they decided to give them their aspirin by mouth or wherever. I'm just picking on Holdenville. But, it's important that you actually don't give the aspirin by mouth. Okay, so we talked about her left-sided weakness. She had an unsteady gait. She was veering to the left because probably her left leg was weak. It was approximately weak. Did you notice on the exam, I didn't go into this in detail, but she's weak proximally. This tells me something, because usually when people are having a stroke, they're actually weak more distally. They're weaker in their hands. So this is the pattern of what we call a watershed infarct. And what that means is usually people have a fixed vascular stenosis, either in the carotid artery, in the intracranial artery, and maybe their blood pressure dropped a little low, or they formed a thrombus and it went and plugged up an area, but not completely. And so based on this, I would expect her to have a carotid stenosis. So how do I figure that out? How do I figure out if somebody has blockage in their carotid artery? What's a test you can order? I'm sorry? Ultrasound is a test. But in this case, she's already had a stroke. That's more of what I consider a screening test. It's not wrong to do, though. That's not a wrong answer. That's not what I'm saying. But usually I'd go ahead and get a CT angiogram. That's going to be your best test. The gold standard test is a conventional angiogram where a doctor goes in through the groin, threads a catheter up, and looks at the carotid artery. The CT angiogram has gotten so good that it's almost just as good as doing that. Okay? There's a few cases that we run into that we need to do the invasive version. So this is her stroke. Here, this is a funny coronal view. This is that diffusion weighted imaging that we talked about earlier, but here's the stroke, this hyper-intense area. Okay? And then the stroke is here. Well, no, I'm sorry, it's on the right side. They gave me the wrong, or I put the wrong picture in. But so this is watershed infarct. So watershed, what I mean by that also is it's where two vascular territories kind of supply closely together. So kind of the border zones, we call them border zones, of the MCA and the PCA artery, or the ACA and the MCA artery. So usually you'll see when somebody has a carotid artery lesion and they're having recurrent TIAs, or they're having recurrent strokes, small strokes, and recovering quickly, you'll see a bunch of speckled diffusion abnormalities along here. Okay? When you get their MRI. Any questions about that case? All right. So here's case number 3. This is a person that comes in with transient left eye blurriness and right hand weakness. So this is a 71-year-old right-handed man. So why do we care if he's right or left-handed?
Effect on lifestyle?
Yeah, that's a good point. What's another reason? So y'all are going to talk about this tomorrow, but most people's language center is on their left side of the brain, and right-handed individuals. And then left-handed people, sometimes it can be on the right side of the brain, but that's still pretty rare. So that's partly the reason why. Because if someone comes in with aphasia, but they have left-sided weakness, then you ask, oh, are they right or left-handed? But he made a very good point. So if somebody's right-handed, and that's their dominant hand, and it's affecting that, you know, for a person that just comes in with right hand weakness, but they're a surgeon, their NIH stroke scale score is probably going to be 0. That score that we grade. And you know, if you read the TPA labeling, it says you only give TPA to people with strokes of NIH stroke scale score 4 or greater. But for that surgeon, that's very disabling, right? To have right hand weakness. Thank for guitars. So. All right, so he comes in with right hand weakness and speech difficulty. He was mixing up his words. Since then, he has had several episodes lasting only a few minutes each. He loses vision or gets blurry vision in his left eye. And then he fell on 3 separate occasions because his right leg suddenly would give out. His doctor examined him and noticed he had a bruit over his left carotid artery. So, what's going on with this patient? So he said his spells only last about 3 to 5 minutes. He's had multiple of them. What is that called?
TIA.
That'd be concerning for a TIA. Again, you can localize the symptoms to where? Left hemisphere. So primarily the left MCA artery. Okay. And then, so why is his vision going blurry in the left eye? I thought the left side of the brain controls the right side of the vision.
Pushing on the optic nerve.
So the first branch off of the internal carotid artery is the ophthalmic artery. It supplies the optic nerve. So have you heard amaurosis fugax? That's what they're trying to get at here. So his big symptoms are recurrent vision loss in the left eye or blurry vision, and he's mixing up his words. What do we call that one? He's not saying what he wants. What's that called? Aphasia, correct. So if someone came in, they told you that they were talking like a drunk person, what is that called?
Dysphonia.
Dysarthria. Good. Y'all are going to be neuro experts. All right. And so we've determined where we think the stroke is. We get a CAT scan. It's read out as no acute stroke identified. And so the ER calls you what to do next. Do you send this patient home? He's back to normal. No. You admit him to the hospital. Okay. So what test would you do? So think about the causes of stroke. Do you think this stroke is due to from the clot coming from his heart?
From his artery.
Good. So you suspect atherosclerosis. But all stroke patients that come in, or TIA patients, standard workup is either a carotid ultrasound, MRA, which is a MR angiogram, a CT angiogram, and then you're always going to get an echocardiogram. You're always going to put them on telemetry and monitor their heart rhythm. You're going to check their hemoglobin A1C and their lipid panel. You're going to check typical other blood work as well. So we'd admit this patient for further workup, and I would highly recommend they get a CTA. So they got a carotid Doppler, and it showed a very tight stenosis of the left internal carotid artery. They did an MRA that confirmed this. And so you find this, and then you consult your fellow vascular surgeon. So usually a symptomatic artery, depending on the size of the stroke, and this is just extra information, if somebody has a carotid stenosis 70% or greater and they're symptomatic, you would definitely intervene on that. So the treatment options are surgery, which is called a carotid endarterectomy, or a stent, which you only usually do if the patient's for some reason not a surgical candidate. So this is the MR angiogram. So this is a gross anatomical picture. So this is what happens over time. You get the thickening of the wall of the artery. And I always explain it to patients like this. If you think about spaghetti noodles. So what happens to spaghetti noodles when you cook them?
Soft.
They become soft and they're mobile. That's a healthy artery. So an artery with atherosclerosis and plaque buildup is like a hard spaghetti noodle. They're easy to break. So what happens when people have carotid stenosis or atherosclerosis anywhere is they have this plaque buildup. That plaque ruptures. And what happens when a plaque ruptures? A bunch of platelets and clotting factors go to that plaque to try and heal it. And you form a clot there, and that clot embolizes to the brain. So it's not that it narrows and you're getting less blood flow that causes the stroke. It's actually you form a clot due to a ruptured plaque, and it embolizes to another artery in the brain to cause a stroke. So, but the surgeon would go in and clean that out. Okay. So, but here's the MRA. You can see this is the right carotid artery. Here, this is the external carotid. Okay, this is common carotid. And there's some stenosis here where the left carotid is normal. Okay. Can you see that stenosis? See how it narrows down like an hourglass? So this is a slide for the differential of a transient neurological spells. So structural, sometimes people can get symptomatic and have weakness due to spinal cord compression, a Chiari malformation, which is an abnormality in the brain. It can be due to stroke. But one of the more common mimics we see is actually migraine. Migraine can actually cause stroke symptoms as well. It can cause people to have tingling and numbness that begins in an area of their hand and gradually progresses up the arm into their face, and they even can lose speech fluency from the migraine. There's a famous video of Serene Branson. She's she's a host, works out of the show, and she suddenly on TV lost her speech fluency, and it turned out she was having a migraine. Everybody thought she was on drugs or had a stroke or all these things, but she had a workup and it was determined it was a migraine. So that's one of the more common causes. And unfortunately, another common cause we see is this one, psychogenic, or what we call functional. But that could be its own 3-hour lecture. So we'll move on. So this is another case. So this is a 64-year-old right-handed male with a history of schizophrenia who suddenly started talking nonsense and repeating himself over and over again. So this is a kind of a complex case because he has schizophrenia. So schizophrenics can actually do this where they talk nonsensically. But he is older, so usually, I'm not saying all schizophrenics, but a lot of schizophrenics don't tend to have as many symptoms. They are usually more withdrawn as they get older, in my experience anyways. So the patient has a history of chronic schizophrenia with occasional auditory hallucinations and paranoid delusions treated with antipsychotic medication. He also has hypertension and a recent episode of chest pain. On the day of admission, he was last seen in his usual state of health at noon. His wife went out shopping, and when she returned at 4 p.m., he was seated at the kitchen table saying meaningless syllables and irrelevant phrases over and over and would not respond to any of her questions. She also noticed that his right arm was hanging down at his side, and she called an ambulance. So from that history, what are the symptoms of this patient? What do you think is going on acutely with him? So he was normal when his wife left at noon, and then she arrived back at 4, and he was abnormal. So what are the abnormal symptoms?
The speech and the hanging arm.
Yep. And then so it's his right arm and his speech. He's just talking, and not listening to her when she talks to him. Okay? So he comes to the ER, gets an examination. On his neurological exam, he responds to all questions by saying only yup, yup, or I don't know repeatedly. This is a common thing patients with aphasia do. You'll be talking to them and they'll just say yep, 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 or no, no, I don't know, or, you know, I'm okay, I'm okay. They commonly repeat those things over and over again. So he was occasionally asked what time it was, and he would just say yep, yep, and not answer the questions appropriately. He kept on repeating words such as Jillian or Lexi multiple times. And it was noticed that he would only blink, so you couldn't get a good visual field on him. He couldn't count the fingers, like our friend up here could, but he only blinked a thread on the left side. He wouldn't blink the thread on the right. He was noticed to have slightly increased tone in the right arm. He could hold his right arm over his head, but not as readily as the left arm. He had an upgoing toe on the right, down on the left, and he seemed to grimace more in response to pinprick on the left side more than the right side. So where do we think his stroke is?
Left.
Left. Good. And then, so this is a common presentation of, so what he has is a sensory aphasia. So sensory aphasia is a Wernicke's aphasia. So meaning that they don't understand what you're saying to them, and they just talk, and they're not going to be frustrated because they don't even know that they're saying the wrong words. But then, as time goes in, sometimes they get, like a patient like this would commonly get sent to a psych facility. Because they would just blame it on his schizophrenia and not check his toes, like all of you will, or check his visual fields to pick out that, oh, this guy's actually having a stroke. So, we would obtain a CAT scan, right? And then here's his CAT scan of the head. Shows a left hemispheric stroke, left temporal parietal region. So the optic radiations come through here. So that's why he has the visual field defect on the right. You won't be able to read. When you ask him to read, won't be able to follow any commands. So common things I ask when I think somebody has aphasia is I say point to the ceiling, touch your nose, and then you make it harder. You say touch your left ear with your right index finger. So this is another picture of his stroke, hypodystheria. There's another case here. So this is a 63-year-old woman who went to her ophthalmologist because she was having episodes of decreased vision in her right eye associated with headaches. Past medical history was notable for diabetes, high cholesterol, coronary artery disease, and for about the past 5 to 6 weeks, she would have sudden onset of blurry, wavy vision off to the right and left-sided headache. Severe left retroorbital headache. She was able to recognize faces during the episodes, but had difficulty reading. She denied any other symptoms 2 days ago. An episode began that resulted in persistent decreased vision on the right side. So what do we call that when someone can't see off to one side? What's that deficit called? Hemianopsia, that's right. So, for both of her toes are down going. She has no weakness. You just note she has a right homonymous, because it's affecting both eyes, hemianopsia. And again, in this setting, most of the time you don't even need to check, have them close one eye or the other, do all that. You literally just stand in front of them, have them look at your nose, how many fingers, how many fingers. If they have a hemianopsia, they're not going to be able to see your fingers on this side, okay? There are some settings, if people come in with monocular vision complaints, that you want them to close their one eye and do it. You'll do both eyes. But in a setting like this where they say, I can't see off to the right, where they come in and they're confused, or they have this aphasia that we talked about earlier, just a gross examination is all you need. So where is the stroke? So she has a right visual field defect. Where's the stroke? Is it in the anterior cerebral artery? What lobe of the brain, I know you're talking about hemisphere, or the cerebrum tomorrow, but what hemisphere controls vision?
Occipital.
Good. So what artery up there is supplying the occipital? You can see it.
Posterior.
Posterior cerebral. So isolated vision loss with no other symptom. As we saw our guy in the last case, that vision loss off to the right. He didn't complain of it, but he picked it up. So this is a PCA. So the optic radiations come through here to the MCA, so sometimes you can catch them here, but they'll have other symptoms. Where with a PCA, a lot of times they'll just have the vision loss, but if it's a proximal occlusion of that PCA artery, there's some additional information. The PCA artery supplies the thalamus. So what would, if somebody had a right homonymous hemianopsia and they had a stroke also to their left thalamus, what other symptoms would you expect? Sensory loss. So they'd have numbness. And if it gets the internal capsule, they'll have paralysis, but they won't have aphasia. Okay? All right. Any questions about that last one?
Where was her headache at? Didn't you say she had a headache with it?
Left.
Like right behind the
PCA
eye?
strokes, I didn't talk about that. PCA strokes commonly in the back part, they tend to be associated with headache. It's not uncommon for people to have retroorbital pain.
Okay.
But if they have a visual field defect like that, it's usually going to be a stroke with that pattern, not a monocular problem, because remember, it's affecting both eyes.
Right.
So it's not going to be a monocular problem. But that's a good question. You'd want to obviously look at their eye and make sure it's not pushing out or something like that, okay? So. All right. This is a 67-year-old female who developed left leg weakness and difficulty using her left hand. She had hypertension, peripheral vascular disease, and smoking, 1 pack a day for 40 years. On the morning of admission, after finishing breakfast, the patient tried to stand up and suddenly found she could not support her weight. She fell against the door, scraping her left side, but managed to reach a telephone and call an ambulance. So abrupt onset of left leg weakness and left hand weakness, trouble walking. So on her exam, she was unaware at times of the weakness on her left side. So what is that called? Begins with an A. Has nose in it. I think I heard somebody say it. Agnosia, anosa agnosia, so you're not aware of your own deficits. Good job. So neglect, she's neglectful of him, is an easier way to think of it. She had some left nosiolabial fold flattening and a mild dysarthria. She was noted to have a, I'm not going to read the details, but had a left hemiparesis involving the left leg, which the leg seemed to be more affected than the arm. Her reflexes were all brisk, if you notice, in the left leg compared to the right. She had absent ankle jerks and her left toe was upgoing. And then she was inconsistent with her sensory exam on the left side as well. Notably, this patient's exam unfortunately worsened. Her exam worsened in that she had extension on the left side to double simultaneous tactile stimulation. So they were touching her on both sides, and she could feel it on the right. and left if you did them separately, but if you did them both at the same time, she was neglectful of the left side. And her left arm was out of control. She was not able to control it. So she has more leg weakness than she does arm weakness. Okay, so what area of the brain controls the leg?
Motor cortex?
More interior, yeah, and higher up, right? In the motor homunculus, if you remember that. So, and then she has what's called, which is in the title, a left alien hand syndrome. She's not aware of her left hand. It just kind of does what it wants to do. This can happen with these anterior cerebral artery strokes. So right there. Okay. All right, and this is two more. This is the second to last case. So this is abrupt onset of trouble walking. So what are we thinking about already? Cerebellar, good. A 70-year-old semi-retired janitor, the history of hypertension, went to work on the one morning at 7 a.m., had sudden onset of nausea, vomiting, and unsteadiness. He was taken to the emergency room where his exam was notable for mild slurred speech and slowing of tongue movements, dysmetria on finger to nose testing on the left, and dysmetria on the heel to shin in the left leg, and left dysdiadokinesia. Upon attempting to stand, he fell to the left, even when he kept his eyes open. The remainder of the exam was unremarkable. So based on the symptoms above, where should it, so we said cerebellum, so which part of, which side of the cerebellum, right or left? Maybe not learned this yet, but. So the cerebellum actually supplies the same side. So it's left. So this would be affecting his left cerebellum. So what are some other possibilities for this guy's symptoms or trouble walking and slurred speech? What else can do that?
Low blood
We've all
sugar?
done it on a Saturday night.
Okay.
So toxins, medications. So, okay. But he had a cerebellar stroke, actually the cerebellar peduncle, which is the superior cerebellar artery. Okay. This is MRI. This is the diffusion weighted imaging. It's right occipital lobe. So right at the superior, you see the part of the occipital lobe, so that's why you know you're high up on the cerebellum. So the cerebellum is supplied by three arteries: the superior cerebellar artery, the posterior inferior cerebellar artery, and the anterior inferior cerebellar artery. So these I included for you all. This is just another picture of that, depicting the supply, the different vascular territories. All right. So this is a 22-year-old woman. Suddenly developed left posterior neck pain, vertigo, ataxia, left facial numbness, and hoarseness after chiropractic neck manipulation. The patient had been well until 4 months previously when she injured her neck in a car accident. She saw a chiropractor daily for neck pain. On the day of admission, after her neck was snapped, she suddenly felt increased pain in the left posterior neck region. As she left the chiropractor's office, she felt dizzy and nauseated and staggered out to her car. She was falling toward the left. She noticed her vision bouncing or swaying. That's called oscillopsia. But had no diplopia. Diplopia means double vision. She vomited twice, and when she reached home, her husband noticed that her voice sounded hoarse. She also felt numbness and tingling on the left side of her face. The symptoms did not improve after a brief nap, so she came to the emergency room. I had to break this one up, but this is her physical exam, so notice the blue regions are the sensory testing, so she has loss of sensation to pinprick and cold. So usually what I do to check cold is I get a tuning fork that I use to check vibratory sensation, and I put it in ice water and then I check and see if they can feel cold. This is her exam. So her left pupil was 2.5 millimeters, constricting to 2 millimeters. Right pupil was 3.5 millimeters, constricting to 2. So she had her pupil was small on the left compared to the right at rest, but constricted down to normal for both with light. That's a clue. She had right beating horizontal and counterclockwise rotatory nystagmus, which increased with rightward gaze. Visual field moving back and forth. She had the oscillopsia. Her extraocular eye movements were okay, except for the nystagmus. She had left-sided ptosis, so droopiness of the eyelid. Decreased pinprick of the left face and the right body. Decreased left corneal reflex. That's where you take a cotton swab or something and you put it on the cornea and they'll blink. Her face was symmetric, face wasn't tested, her voice was hoarse. She had decreased palate elevation on the left and decreased left gag reflex. Both toes were downgoing, reflexes were symmetric. She had ataxia on finger, nose, finger, and toe tapping on the left was irregular rhythm. So decreased pinprick and temperature and sensation in the right limbs, we talked about. So on the basis of the symptoms and sign, so the big thing is she had crossed findings, right? Brainstem. For a new Buick, what's the name of the syndrome? Horner's. Yeah. Well, that Horner's is causing the ptosis, but what's the name of the stroke syndrome? You get bonus points. Or Dr. McNeil will buy you a new Buick. So we established it's in the brainstem. So this is called a Wallenberg syndrome. Okay. So it's the lateral medullary stroke, and I actually had a case of this 2 weeks ago in a young woman. So what do you think, where does the neck pain come in? What do you think that's about? Is that relevant to her case?
Wasn't that a car accident?
Yeah, she was in a car accident. Do you think the neck pain is relevant?
No.
Is anyone a chiropractor? Anyone married to a chiropractor? No? Anybody go to the chiropractor?
Yes.
It's okay if you do. Just asking. So this is so the clue, the neck pain is relevant. So why do you think it's relevant?
Because she's feeling
What
pain.
happens, huh?
Because she's still feeling pain?
Yeah. So she has a dissection, a vertebral dissection. So commonly when people are manipulated by the chiropractor, I want to say it's 1 in 500 or something, they can get a dissection from neck manipulation. Maybe it's a little higher than that, but we see this on occasion. I see it about 2 or 3 times a year.
When we were talking about the brainstem and the vascular supply, I mentioned that the medial part of the brainstem will produce different symptoms
Mm-hmm.
than the lateral part of the brainstem if there's a stroke.
Yep,
And I didn't name it, but that's what he's talking about.
yep. This is the lateral part, and I included a bunch of slides showing the vascular supply of those in the different syndromes. But yeah, this is called Wallenberg, or a lateral medullary stroke. So that she does have a Horner syndrome that you picked up on. So she had a small pupil on the left and a larger pupil on the right. And actually, what I do, I don't shine the light, I actually turn off the lights, and the difference will get bigger. So that left pupil won't dilate. You cut off those sympathetic fibers. So, and then they have a little bit of a ptosis, and then they're going to be hoarse. And then they'll have cross side numbness. They won't complain of the right body numbness, by the way. They won't notice it until they take a hot shower or they take something, because it's mainly temperature. And you'll see that when you get to the, because what tract, have they gone over tracts? So what tract controls pain and temperature? Good job. That's super smart. When I ask the ER residents, we're ER doctors, we don't localize, they say. So this is her stroke. This is my favorite. I mean, I don't like seeing anybody with a stroke, but this is my favorite stroke to diagnose. This is, you can do it at the bedside. Look at that, classic findings. All right. So these are common vertebrobasilar ischemia, so what I call posterior circulation stroke symptoms. Dizziness, because it can affect the vestibular nuclei, the cerebellum can even lead to dizziness. But dizziness is nonspecific. You know, dizziness, again, you can give a whole lecture over dizziness, and providers hate saying dizziness because most causes of dizziness are not dangerous at all, not life-threatening, but there's a small percentage of dizziness, mainly cerebellar stroke, that people worry about. And then obviously dizziness can also mean lightheadedness. Dizziness can mean trouble walking. Dizziness can mean spinning. So when you're taking a history, you got to see what the patient means by dizziness. Is there something that triggers it? Does it happen when they roll over in bed? Does it only happen when they stand up? Those are all important factors. Double vision. In most strokes, by the way, will not have dizziness as an isolated symptom. That's very uncommon. Not impossible, but pretty uncommon. They'll have other findings on their exam. So double vision or disconjugate gaze, meaning their eyes don't move together. Other visual disturbances, trouble walking, incoordination, unsteady gait, ataxia when you examine them. Dysarthria, okay, this is where the dysarthria comes in. So that's trouble with articulation. They can have numbness or tingling. Again, remember the crossed findings. And then they can have hemiparesis or quadriparesis if it's a big pontine stroke. And they can be sleepy because of the reticular activating system, or if they knocked out both of their thalami, they'll be sleepy. So these are the different artery territories. And up here, as he talked about, the lateral part of the brainstem is supplied differently than the medial part of the brainstem. Okay? The pica is what supplies that lateral medulla. So the posterior inferior cerebellar artery comes off to the vertebral artery. So these are different midbrain vascular syndromes. I'm not going to read it to you because, again, you will get this slide set. I thought this was a good table of all the different stroke syndromes. And they're associated, they have names with them. You know, I personally don't think you need to memorize those. I don't think that's something I would learn. It's mainly just understanding, you know, the symptoms that brainstem strokes cause. So a third nerve palsy, numbness on one side of the face, and cross findings. So with this syndrome, let's see, forgot which one. Weber's, yeah, they'll have a third nerve palsy, and sometimes they'll be ataxic on the right side. So those are things. So this is midbrain. This is just an anatomical picture for you to remind you where the nuclei are that you're learning in neuroanatomy. These are the pontine syndromes, okay? There's more of those. So there's the rostral pons, which is at the top, and then you have the caudal pons, which is more inferior. And then the medullary vascular syndromes, which we covered one, the lateral medullary, which is the Wallenberg syndrome, okay? And then you have the medial medullary syndrome. It will produce different symptoms. In the medial medullary syndrome, we're not talking about spinal cord today, but this can mimic what we call myelopathy, or a spinal cord abnormality, because of the way it affects. You lose vibratory sensation, and you have hemiparesis usually just involving the arm and the leg, rather than there's no face or cranial nerve involvement. And then I just included a table that talks about all the different hemispheric stroke syndromes, so that will be helpful for you, I think, for tomorrow, your lecture tomorrow. And that's it. Any questions about stroke? That was a lot of information.